Welcome, and thank you very much for joining us. Our last presenter for today is Dr. Lisa Matsuvag. Dr. Matsuvag is a pediatric audiologist with over 20 years of clinical experience and leadership in the field. She serves as the study coordinator for the Path for PWS project, which is sponsored by the Foundation for Prader-Willi Research. Dr. Matsuvag is going to report on the occurrence of serious medical events in PWS identified in the Pws Study. Dr. Matsuvag.
Thank you very much. Welcome, everyone. I hope everybody can see my slides okay. As Dr. Pws mentioned, I am Lisa Matsuvag. I am the Path for PWS study coordinator, and I'm going to give you a little bit of an overview of some of our preliminary findings from the study today. Bear with me one moment. There we go. So, what is the Path for PWS study? For those of you who may not be familiar, it is a 4-year prospective non-interventional study in which we ask respondents of caregivers of people with PWS to complete a series of surveys every 6 months. These surveys are housed in the Global PWS Registry, and they collect information on things like height and weight, as well as behavioral assessments, including the Hyperphagia and Food Behavior Survey, the Food Safe Zone, the PWS Profile, and a detailed report on serious medical events and thrombotic events that are occurring. As part of the Pws study, there was also a D-dimer sub-study, which concluded in September of 2019. There are many benefits to the PWS community for the study. First and foremost is a better understanding of the natural history of Prader-Willi syndrome. We're hoping this will help guide research and standards of care in PWS. It will also provide a reference data set for comparison for new drugs for PWS as they're evaluated, and hopefully inform new development of, for new therapies for PWS. This study was in large part due to collaboration from multiple community partners. We closed enrollment on July 1st, 2019, enrolling 700 families. We had collaboration with multiple PWS organizations in the US, Canada, Australia, and New Zealand. We utilized a number of methods to enroll individuals, including targeted marketing, emails, social media, and so forth. We also collaborated with some PWS residential facilities, as well as PWS clinics around the US. After enrollment, we looked at the number of individuals that completed initial surveys, and we had 647 respondents complete those initial surveys. People aged 5 and older were able to enroll, and you can see here the distribution of the ages is fairly equal across each of the age groups from 5 to 11, 12 to 17, and 18 and older. And most notably, we have almost 40% of our participants in the 18 and older category, meaning we're really learning a lot about the adult experience with PWS. There's equal distribution of male and female participants, and participants reside in the countries listed below: the US, Canada, Australia, and New Zealand. And I'm really happy to report that there's been a high level of commitment to this process. We have a retention rate of 93% of the respondents who continue to complete surveys every 6 months. As part of this process, parents and caregivers are asked to document any serious medical events that may occur every 6 months. This includes a detailed description of the event, things that lead the person to go to the hospital, urgent care, ER, anything that is outside of the daily routine of the person with PWS. We collect information on the date in which the event occurred and changes to the medication. And for each documented event, I generate a report that is de-identified. I often call respondents for additional details to complete a comprehensive overview of what the event entailed. We review medications, and then this de-identified report is sent to the study investigators for comment. Event terms are generated, and we will be using those to code for MEDRA coding. Here you can see a number of different types of serious medical events that have been documented thus far, though this isn't comprehensive of everything that we've seen. Commonly and not unexpectedly are GI issues, psychosis and mental health issues, spinal surgeries, broken bones, seizures, and so forth. We took a look at the total number of serious medical events documented since the inception of the study through March of 2021, and we had 314 total events documented. So of the 647 participants, 214 of those, or 33%, documented some type of serious medical event since the inception of the study. And further, we looked at those that had multiple events since the start of the study. So of the total that documented an event, 214, 37.7% of those had more than one event occur. And again, of the total 214, we also looked at how many individuals had multiple events occurring in a 6-month time frame. And that was a surprising number as well. 20.5% of individuals had multiple events each time they completed a survey. The most common types of serious medical events that we're seeing are mental health in nature, followed by GI issues, and also broken bones and sprains and seizures. And the remaining types of events encompass a wide range of medical events. In the documentation, we do collect the names of the current medications and the reasons for treatment, be it endocrine, metabolism, GI, and so forth. Parents are given these categories to select from, or if it's another category, they can quantify what the medication is being used for. We also collect data on the route of administration, and we are seeing that polypharmacy, or the use of a drug for one indication, is quite common in our population. Moving on, we also looked at some information from the Hyperphagia and Food Behavior Survey. This survey includes both the HQCT as well as additional food behavior questions. So those food behavior questions were implemented into the survey in October of 2018, but we also added some new questions to the survey in March of 2021. Again, respondents take this survey every 6 months, and we collect information on height and weight. The questions address issues of sneaking food, talking about food, responses to being denied food, and how that looks in the individual with PWS. We did a preliminary analysis from the subset of the PATH participants who completed the Hyperphagia and Food Behavior Survey. And of those 647 responses, only those that had no significant life changes, those who were enrolled, who were not enrolled in a clinical trial, and those with a caregiver who was very familiar with the daily activity of the participant were included. So this left us with 460 responses for our analysis. The data from the 480 responses was broken down by age groups 5 to 10, 12 to 17, and 18 and older, with the majority of the responses from participants aged 19 years and younger. It was found that the HQCT scores increased with age. The average HQCT scores in the 5 to 11 age group were 9.29, while in the 18 and older group, you can see that the average scores were 11.21. Though notably, there are some older adults with lower HQCT scores, which we plan to do further analysis on in a future project. So the next question then is why that may be occurring. I think there are a lot of possibilities as to why scores may be lower than expected or lower than what has been reported in clinical trials. One thought may be that independent administration of the HQCT hasn't been validated. We are also looking at a subset of participants that aren't just enrolled in clinical trials, but are encompassing the greater range of PWS population. So scores may be higher for those seeking to enter clinical trials because they are in need of that treatment compared to a natural history study where some may not be experiencing as much hyperphagia at the age that they're at. Hyperphagic behaviors may also be present, but the family maybe has become so used to the things that they do at home to ensure safety that perhaps they don't think about those things when they're scoring the survey. And environmental controls may sort of artificially depress those scores. And scores may also be lower in environments where there's access to food because the levels of stress may be lower. Here we see the average HQCT scores and the food safe zone scores are higher in participants with a higher BMI. We also looked at the relationship of the HQCT and the food safe zone. For reference, the food safe zone was developed by Elizabeth Dykins and Elizabeth Roof to assess the safety measures that are in place to provide food security in the environment of the person with PWS. And the HQCT is a measure of food seeking behaviors. In this analysis, we used the same 460 participants, and HQCT scores were found to be higher in individuals with higher food safe zone scores. One interpretation may be that as hyperphagia increases, the caregiver increases the way in which food security is implemented in the environment. There may be a subset of people with PWS who display more aggressive food seeking behaviors despite the food security, and they're still able to access food. We need to learn more about the relationship between these two measures. And one question we will be looking more at is the relationship between a higher food safe zone score and the relationship to anxiety. Additionally, this gives some information about those additional food behavior questions that are contained in the hyperphagia and food behavior survey. So this slide shows the relationship between the HQCT and the additional food behavior questions contained in that survey. These additional questions were designed taking into account feedback from caregivers and clinicians based on observable behaviors in a person with PWS. Answers to the questions in purple have been in the survey since 2018, and we've been collecting data on it since that time. The questions in blue were recently added to the survey in March of 2021. From the scatter plot, you can see even those with lower HQCT scores may have many have scored higher on the food behavior questions, suggesting maybe these are a valuable indicators for early hyperphagia behaviors. And by the end of the Pws study, we will reevaluate the characteristics of the new questions relative to the HQCT scores. We also wanted to address the issue of medication, since we're collecting that data through the serious medical events survey, and address the question of the polypharmacy. So looking at these graphs here, you see a breakdown of information by age group, age 5 to 10, age 11 to 17, and age 18 plus. We saw a significant increase in the use of multiple behavior psych meds with increasing age. In fact, some individuals are taking up to 6 medications for this indication. In the 18 and plus category, approximately 65% of the participants are taking one or more of the behavior psych medications. And I'd like to make note of the young age at which some participants are being prescribed these medications. And in some instances, you see in the 5 to 10-year-old age group, you have 33% of the participants being prescribed these medications, and as much as 5% taking 3 to 4 medications for this indication. I don't think that's surprising, because when we look back at the documented serious medical events category, mental health events are the top documented reason that people with PWS are experiencing a serious medical event. And the percentages of these individuals using medications combined with those serious medical events, I think it's clear that this aspect of PWS is very, very challenging for families. Lastly, I just wanted to show some of the information about the types of behavior psych meds broken down by age group. So use of these medications, again, is common in PWS, and the percentage of people using these medications does increase significantly with age, as we saw on the previous slide. And again, polypharmacy is quite common. Here we see the percentage of people using these medications based on the classification, such as anti-anxiety, antipsychotic, ADHD, etc. In the younger population, use of medications classified as ADHD drugs are most commonly seen, followed by antidepressants. But as the person with PWS ages, we see a significant increase in the use of antidepressants, antipsychotics, and mood stabilizing medications. And here I'd like to end by acknowledging all of the contributors to the Pws study. Teresa Strong is the lead investigator on the Pws study, but we'd also like to acknowledge the contributions of Dr. Jennifer Miller and Dr. Sean McCandless as the study investigators for Pws, as well as Dr. Elizabeth Dykins and Elizabeth Roof for their development of the clinical trial measures, the PWS profile, and the food safe zone, which are contained in the global PWS registry, as well as in the Pws study. And lastly, I really want to thank each of the respondents that have enrolled in this study and taken the time to answer all of the survey questions. You've entered entertained all of my phone calls, emails, and reminder texts to document all of the medical events and complete the survey updates faithfully. The success of this study is in large part due to the commitment of the parents and caregivers, and we're grateful for their contributions to this study. So with that, I'd like to end my talk and thank everybody for attending. If you have any questions, please feel free to ask. And I've also included my contact information should you need to reach out and have any other questions answered.
Wow, well, thanks so much. That was a terrific presentation. It's such an important data set. And I think, you know, it's critical to really evaluate these elements over time and life course. I wondered about some drift in your sample composition with age and gender, things, you know, PWS subtype. I can't remember the data on the PWS subtypes because you could see some change in the composition, potentially reporting if individuals are developing severe mental health problems. Would it, have you looked at that data at all for drift in reporting?
We have not broken it down by subtype yet. Again, these are some preliminary findings. We are looking at it more based on age and the frequency with which these things are being documented, as well as the polypharmacy across age. But we certainly will be looking at that closer as the study gets closer to the end.
Yeah, because I wonder about hyperphagia in particular, you know, gender differences. And I also worry a little bit, and I couldn't establish this directly with mortality curves, but differential effects on mortality, that you might start seeing one subtype over the other and start getting different manifestations. And if individuals become severely psychiatrically ill and with uniperotostomy, that's going to affect their hyperphagia reactions and stuff. So maybe what you're seeing is somehow a manifestation of the disease course in different populations, which would be hard to assess.
We absolutely want to look at it based on subtype because, you know, that is data that we are collecting in the study. So we'll have a number of metrics in which we'll be able to break down the data in much greater detail as the months go by and we continue to collect data.
Fantastic. I think it's terrific. I'm not seeing any other questions. Anybody want to put some questions in the chat, in the QA? Dr. Pws, do you have any comments?
Well, you know, I can't help but think about how important that data is. I mean, the question about polypharmacy, you know, that was really quite evident, and I think evident to, you know, folks in the community that that's going to, you know, continue to drive other comorbidities that patients really have to address, you know, and so that was, you know, a good breakdown looking at it, and also what the medications, you know, kind of say about the course. You know, I thought that, you know, the child and, you know, younger data, you know, how it kind of changes, you know, in a relatively short period of time, I thought was quite telling and you know, able to kind of illustrate some of the issues that people experience. So
I agree. Yeah, I think, you know, just looking at the medications and the stark similarities to the number of mental health issues that are being documented by parents and caregivers in the serious medical events survey, it didn't surprise me, but I think as a parent, I don't think I fully appreciated when my son was younger and we were first learning about PWS that this would be as significant a part of our course of daily life with PWS as this study seems to be illustrating.
Great, and we did have one question about individuals who might join the study. Did you close the study, or are you still recruiting?
We are not currently recruiting for this study. However, as I mentioned, there are a number of surveys that are in the study portion that are also contained in the Global PWS Registry. So if an individual wants to participate and provide some data and contribute to the research, they can do so by creating an account in the Global PWS Registry. In fact, again, my contact information at the end, if you're having any difficulty accessing the registry or creating the account, I'm always happy to help with that. But we are gathering that data for everyone that is in the registry that chooses to complete those surveys. The only survey that isn't open and available to everyone in the registry that is specific to the Pws study is the serious medical events and thrombotic event survey.
All right, I think that we're going to have to wrap up. Thank you so much, and we'll invite people to the closing live stream here at 5:40 Eastern time, I believe. So thank you so much.
Excellent.
Wonderful presentation. I really appreciate it.
Thank you so much. And you guys have done a great job with the conference. I appreciate it.
Thank you.